time of the conference. Okay.
Yeah, from 2016 onwards.
Great. So thanks very much, John and colleagues. So my name is Sean Dinneen. I'm a diabetes doctor here in Galway in the west of Ireland, and I've been aware, I guess, for some years now that, in my opinion, you know, we don't really meet the care needs of our, particularly our young adults with type 1 diabetes. They generally, as best we can tell, they tend to have poor outcomes. I'll take you through some of that shortly in my presentation. And we have for some time now been trying to work on why that is, understand why it is, and how we might reimagine care for this group. And Eimear, my colleague Eimear Morrissey, who's joining me today, is part of a health behaviour change research group in NUI Galway. I'm based in the hospital here in Galway, and my colleague Molly Byrne, who's a professor of health behaviour change, health psychology, has been a fantastic collaborator on this journey, which it's scary when we're asked to put it together now. It spans already you know, a good few years of our work. So I'll start sharing the screen, and let's see if I can do this. So can you see that? Oops, let me just go to slide number 1. Yeah, you can see that there, the opening slide. Yeah, the title slide. Okay, so this is a very busy slide with stuff all over the place, but our journey began back in about 2012 when we decided to do an audit of our cohort of young adults attending our clinic in Galway. We had at the time about, I think it's somewhere on this slide, about 120 or so young people, 137 actually in our clinic cohort. And you can see this was in old money, or I guess in Canada it's still the way you report A1C, but the overall control was poor. So averaging about, you know, close to, well, 9.5% I think is where it came out. And you know, we were not pleased or not proud of this, and so we set about trying to understand it a little bit better. What we found straight away was that we were not alone. This is now in not in percentage, but in millimole per litre, which is how we report A1C here in Ireland and in the UK. So across the whatever number of provinces or regions of Scotland, we linked up with a colleague in Edinburgh who has a similar interest, and you can see actually if you work it out, it's Galway, when we plonk it into the middle of Scottish regions, is right at the median. So 81 millimole per litre was from the previous slide in terms of A1C average. And you can see that there are as many regions of Scotland higher than that as there are lower, and the lowest is 73. When you think of where we should be aiming for, you know, 53 millimoles per mole would be 7% A1C. We're really not doing great. And this isn't just a phenomenon in the UK and Ireland. This is type 1 diabetes exchange clinic registry data published in Diabetes Care in 2015. And you know, you can see that with a huge number of young people involved, you can see there are relatively few in the older age group, as you might expect with type 1, but the majority are here, and really, you know, poor control by any stretch of the imagination in that sort of 18 to 25 year age group. So what we set about doing was, as I say, trying to understand it. One thing that came out of our audit, which even now, 7 or 8 years on, is still something that is quite remarkable for me, is that one of our diabetes nurses who was trying to track A1C data on our laboratory system came across and came up to me and asked, Sean, what is vitreous glucose? And I asked her, I knew the answer, but I said, was it the last entry on the lab system? She said it was. And vitreous glucose, for those of you who are not aware, is how the coroner tries to identify pre-mortem glucose levels in the post-mortem setting. So one of our young adults was dead. And this was something that, you know, was a massive jolt to us. The story was not untypical for young adults. She had moved around a bit. She passed through our clinic and had linked up with another clinic in another part of the country. But we still don't know exactly the circumstances. But this isn't just about morbidity. This is also about mortality. And again, you know, these data from England, a very, very detailed mortality audit across England, shows that if you are a young male with type 1 diabetes, you have close to a 4-fold increased risk of death. If you're a young female, it's really quite scary, and you have up to a 7-fold increased risk of death. And this is not death from the long-term complications of diabetes. This is probably, you know, DKA or getting it wrong on a night out in terms of hypoglycemia and so on. So that episode, that single event, has been a catalyst for us in terms of, you know, trying to reimagine how we deliver care and trying to understand why outcomes are poor. This is how we deliver care. This is actually when I worked in the UK before I got grey hair when I came to Ireland. But it's the only image I have of the office. So this is a hospital doctor's office, and we tend to bring people up to the center, to the hospital, and we quiz them, often in their eyes, quiz them on their day-to-day living, and then report card them, sort of, you know, how they're doing, good, bad, or somewhere in the middle. And really, I think this doesn't work for a lot of young people. So this is back-to-back 2 young women who I saw in that room in Addenbrooke's in Cambridge. One presenting a dog-eared, blood-stained, dirty, you know, record book. This is before CGM became widely available, but very real, different pen and pencil and whatever was handy to write down the numbers. A1C at that time, about 8.5%. This is the next person who came into the room, pristine record book, all the numbers in exactly the range that she knew that I wanted to see. And so, you know, A1C about 12%. So you can tell that, you know, this is fictional, this is factual. And so what do you do in this scenario? Do you bang your fist on the table and say, what the hell is going on here? Of course you don't. But, you know, this is the reality. And so, you know, how to reimagine it is not easy. One of the projects that we undertook, Lisa Hines, who worked with Molly Byrne, did her PhD on barriers and facilitators to attendance at hospital diabetes clinic. And this work, Lisa's work, has really informed our kind of direction of travel with our D1 Now study, and our, you know, our clinical trial, our pilot clinical trial that Eimear will tell you about. Because, you know, what we have recognized is from Lisa's work is that a lot of this is around the relationships between the young adult and the service providers. And that relationship can be through traditional clinic visits, but it can also be through, you know, hospital encounters, you know, hassles associated with clinic. It all of the contacts, if they're managed properly, build that relationship and hopefully lead to, you know, improved clinic attendance. So we set about trying to reimagine care. We thought of interventions maybe at the family level. We were less interested in that because we tend to see 18 to 25-year-olds, college-age students who have left home usually. We thought about interventions at the individual level. Wicked is a program delivered to adolescents in Sheffield in the UK. So structured education or maybe goal setting. Again, we were less excited about that. We felt that where we could benefit was in the clinic organization, the way we organize care for our young people. And that's the journey that we've been on. So one thing that we've done that has been hugely beneficial is we've learned from a youth mental health service here in Galway, a national service, but with a very excellent service delivered in Galway. And this is where the idea for our co-creation or our reaching out to young people came from. And for about maybe 6 years now, we've had a young adult panel or a YAP as an example. In Ireland and the UK, we talk about public and patient involvement. And this has been a tremendously rich and rewarding experience for us. In being open to the ideas of our young adults and trying to listen to them, in a meaningful way and hear what they have to say and let that kind of shape our work. The conference that I'll tell you about in a moment, up to recently, that was probably the most inspiring couple of days that I've spent in terms of my own career, my own research career. But actually, I think it was trumped by, excuse that terrible word, it was trumped by the YAP meeting we had on just this past Monday when Eimear and some of our colleagues on the team presented preliminary data from our pilot. And it was just phenomenal to have the young people who've been with us from the beginning, listen to the preliminary results and start thinking about what they mean. So fantastic meeting and well done to Eimear, for organizing it. So relevant to yourselves then, we felt that our intervention would need components like supporting self-management, engaging young adults in clinic attendance. We felt some innovative ideas around service delivery, but also digital technology. We felt that had to be part. This is not just CGM and pumps. This is about using the digital environment to try to keep in contact, keep young people engaged. So that's what we set out to do. And over the 2 days, it happened to be the 2 days of the Brexit referendum and results. I'll never forget it. It was June 2016. And on the evening before, we had this fantastic walkabout when we had all the conference speakers and some of the attendees kind of join us on a walking tour of Galway. So these are some of the images from that walk. We live in a medieval city in the west of Ireland, and we got a great we were sort of getting the juices flowing, the creative juices flowing, I guess, on that evening. And then the next day, I might have the order wrong, but we had a conference with 110 delegates registered, at least 10% of whom were young people living with type 1 or their family or significant others. And then we had this expert panel where we tried to distill out, a lot of the ideas that we were kind of coming up with from Lisa Heinz's work and other strands of our work, and trying to bottom out an intervention that we could design and bring forward for funding. So this I think is the expert panel that was organized by Molly and her colleagues. And this then is the hackathon. So this idea came from a colleague of ours who works for HSE, our health service executive for the digital part. And I think his job is to run hackathons. And because we felt there was going to be an IT or a digital solution or element to our intervention. So I can try to put you in touch with him, but he's the professional. I'm not sure I can do justice to describing how he did, but it was absolutely fantastic. So we formed 4 teams made up of a young person living with type 1, some healthcare professionals involved in diabetes care. We had researchers, and then we had others. Others being maybe ICT or tech savvy people. And they met, each of the 4 teams met for a couple of hours at least on the evening before the hackathon to try to, agree their priorities. And then on the day of the hackathon, they met in a group, and it was like a sort of a sweatshop. They had a certain amount of time, a day, I think it was, and they had to come up with a presentation or a pitch at the end. And then we all adjudicated on that, and we came up with a winner that was meant to be the idea that we would take forward. So it was fantastic, I have to say, and the buzz in the room or around the place for the day was just phenomenal, and that's where our D1 Now intervention came from. So I think that's where I stop and hand over. I'll stop sharing there, and in preparing for this, I actually found this was Mary Claire was a former colleague of ours, a program manager who's moved on now to the HSE R&D section. But I have a CD with the 4 pitches on it, so I can try and figure out, you know, I'd be very happy to share them with you. But rather than flying this disc to Canada, we'll try and get the, and I hope you get a sense from it of the buzz. You know, there was a real buzz in the room, and I think part of the hackathon is again oiling those wheels, or those creative juices, getting them flowing. And you know, that was definitely done. I didn't do it, you know, but it was a wonderful, you know, couple of days between the conference, the expert panel, and the hackathon.
Wonderful. That's fantastic. So over to you, Eimear.
Yeah, sure. Can you see my screen? Desktop, sure.
That was fantastic, Sean. Thank you very much.
Great.
Okay, so you can see this?
Yep.
Yep.
Great. So I think Sean has brought us quite nicely up to about 2016 there. I'm just going to give a small bit of background on our young adult panel and kind of the makeup of our young adult panel. So as Sean mentioned, I think the work started kind of in 2012, 2013. I think it was around 2014. Recruitment started for the young adult panel. So we were linked in with Jigsaw, who are that mental health youth service in Galway. They actually have a youth advisory panel as part of their setup. So they were able to give us lots of advice and help around setting up our own young adult panel. So initially we had 8 members, all young adults living with type 1 diabetes, in between roughly 18 to 25. So it's been running for a long time now, and some young adults have left us and some have stayed on. Obviously, young adulthood is a time of transitions and changes, and many people have left Galway or even left the country. So we've had 3 rounds of recruitment, the initial one in 2014, another round in 2017, and then we recruited again in 2019. So we've had over 20 young adults have been involved since the beginning, and at the moment we have 11, and some of those are still with us from the very beginning. So I mean, they're absolute experts on this at this stage. They know way more about the project than I do, for example. So just how it works in practice, we have meetings every month. We used to have them in person with people who weren't in Galway video calling in, but now they're video calls every month. They usually last between an hour or 2 hours sometimes if we have a lot of tasks to get through. Then we have contact in between meetings if we need to. We have a WhatsApp group. We share documents over email, and we also have a shared Google Drive folder. That's actually really useful because everybody can go in and out of it and change and edit things. And we have a young adult panel member on the steering group for our project. So they're kind of involved in every way. So back to D1 now, I suppose around in 2016, around the time of the Strength in Numbers conference, we didn't know exactly what the intervention was going to look like. We knew that we wanted to develop an intervention to support self-management in young adults with type 1. And we knew, really importantly, that we wanted to have the young adults themselves involved in every single step along the way. So the Strength in Numbers conference that Sean has talked about happened, including the hackathon. Another event that happened at it was an event around coming up with a core outcome set for clinical trials with young adults who are living with type 1 diabetes. So a core outcome set of 8 outcomes, I think, was decided on. That paper has been published, so I can send that on if that's of interest to anybody. And from that, the D1 Now intervention was born. So we knew it was going to have 3 components. The first one was a support worker. Sean mentioned that one of the problems with clinic attendance for young adults is that they don't have a good relationship with the clinic. Often that's because they're meeting a different healthcare professional every time they go into the clinic, and there's just not that sense of continuity. So a support worker was an intervention component we decided on, mainly to provide that sense of continuity and build a relationship with the young adult. An agenda setting tool was also going to be part of the intervention component components, and I can show you that now. And also the digital side, we had decided on Florence, which is an SMS messaging service. So the support worker, we didn't know very much about exactly what that person would look like. We knew it'd be someone who would provide a sense of continuity, who would act as an advocate for the young adult and who could contact the young adult between appointments if needed. We didn't know exactly who that person would be. Would they be a nurse? Would they be a community, a youth worker, maybe a psychologist? We weren't really sure. In terms of Florence, which is the interactive messaging service, so that kind of came with a pre-packaged kind of types of messages it can send. It can send blood glucose checking reminders. It can send alcohol safety reminders, reminders of the sick day rules, and motivational messages as well. So we had a good enough idea of what that was going to look like. And then in terms of the agenda setting tool, we did a scoping review of agenda setting tools that are out there and came across this one that was developed by Patrick Chowdhury in King's College in London. So Dave developed this, what they call the T1C tool, so the type 1 consultation tool. And it's a 3-page form that the person who's living with type 1 fills out in the waiting room before they go into their appointment. Probably the most important part of it is there's a question at the beginning that says, what do you want to talk about in your appointment today? And then it includes measures of things like diabetes distress, hypo-awareness, and A1C as well. So we kind of had that idea of what the intervention would look like, but at that stage we didn't have any money. So we applied to the Health Research Board in Ireland to fund the intervention kind of refinement and piloting work. The Young Adult Panel were instrumental in that application. They helped out with a lot of it and wrote pieces of it. And we were successful in gaining funding to continue on with this work. So as I said, we had those kind of rough ideas of the intervention components. We knew they needed to be refined further. So we knew we were going to do that probably through qualitative research. So the Young Adult Panel got involved with it. We were very lucky in NUI Galway. We host the TMRN in Ireland, so the Trials Methodology Research Network. And within that, there's a subgroup called Quests. So they are the group who kind of deal with qualitative research in trials. So we were very fortunate. One of the members of Quests was able to facilitate qualitative training for the Young Adult Panel, bringing them through the basics of qualitative work, how you conduct qualitative research and how the different ways of analysing qualitative data. So from that, it was decided that the app could have 3 or 4 different kinds of roles, depending on how involved they kind of wanted to be with it. So it could kind of be level 1, where they would just coordinate the focus group. So get all the contact details, figure out a time and place. If they wanted more involvement, they could coordinate the field notes, actually attend the focus group. Similarly, they could attend the focus group and facilitate the debriefs, or if they really wanted to be very involved, they could co-facilitate the research group with one of the researchers. So I think between the Young Adult Panel, they all did different levels of it. So I think all 4 levels were kind of undertaken. So we needed to refine the draft intervention components, and we also needed to make sure they were feasible in practice. So we did this through interviews and focus groups with young adults and with staff and diabetes clinics. So the Young Adult Panel members took part in the data collection in those roles I've previously specified, but they also played a really crucial role in our analysis. So how we went about analysing for our qualitative work was we went through every transcript. So the young adults and healthcare staff would have used the intervention components, and they would have talked about what they liked or didn't like, what they thought should be kept or what could be thrown out. We went through each transcript, and anything that identified a barrier or made a suggestion for change were tabulated. Then we brought all those to the Young Adult Panel, and then we implemented a modification if it had been deemed acceptable and useful by the Young Adult Panel members. So we ended up with a refined intervention. So this was the original agenda setting tool based on Patrick Chowdhury's work in King's. So you can see it's a 3-page document. The middle page really focuses on kind of clinical measures and things that would be taken from the patient's chart. So through the qualitative work, it was decided that should be dropped. And then the tool was kind of further refined for a young adult and Irish context. So we put in, I think, like references to college, to alcohol and drug taking, and just made it more applicable to that young adult audience. In terms of Florence, which is the interactive messaging system, I'd mentioned that they came with kind of this pre-package of message protocols. So we did a lot of work around editing those. So just one example here is that it can send out a reminder to check your blood glucose at certain times of the day. If you text back a reading that's out of your target, it responds with a breach message and tells you to contact your diabetes clinic. So during the qualitative work, most young adults said, look, I would never contact the clinic if I only had one out of target reading. The app agreed with that, thought a change should be made. So we changed it that you had to have 3 out of target readings in a row before you get a breach message. So that's just one example of the refinement that went into that. We did a lot of refining work around the wording of the messages, so they suited that young adult and Irish context. And then finally, the support worker. So as I had said previously, we didn't really know very much about what that person would look like, but through our qualitative work and the work with the young adult panel, we came up with this job spec. And you can see here what we looked for in terms of qualifications in the end was a qualification in nursing, or mental health nursing, or psychology, or social work, or allied care. So we kept it quite broad. We did put in this piece that they had to have experience of working with clinical populations and ideally young people with long-term conditions. And then it all became very real, and we hired a support worker in 2019. So as I said, the job spec had been drawn up by the app and the research team, and a member of the young adult panel sat on the interview panel and interviewed the candidates. So this is Michelle. She's our D1 now support worker. She's an occupational therapist by training, but her background is in where she works is in youth mental health. So we had our 3 intervention components there drawn up and ready to go. So the next step was a pilot randomised control trial. So we're just finishing this up as we speak. It started in October 2019 and ran to January 2021. So it's a 12-month intervention. So we recruited from October 2019 to January 2020. So it's been running for those 12 months. So we have 4 diabetes clinics in Dublin who are involved. We've 3 in the intervention group and 1 in the control group, and around 15 to 20 young adults taking part in each clinic. So in terms of our outcome measures for the pilot trial, we are using the core outcome set that was decided on during the Strength in Numbers conference. So some of that is self-report measures, so things like diabetes-related self-management, empowerment. There's a few others as well that are self-report. So they're measured within a questionnaire, and then the clinical measures are collected in the clinic. So the role of the young adult panel within this was that they tested and refined the booklet of questionnaires. So while we had core outcomes, we didn't always have an operationalization of them. So I think a good example is this one. So one of the core outcomes is the number of episodes of DKA the young adult has had in the last 12 months. So I foolishly thought that everybody who lives with type 1 diabetes would know what words like hyperglycemia, ketoacidosis, and ketonuria would mean. So I just Googled the definition of DKA and put it in, and just assumed that wouldn't be a problem. Showed it to the young adult panel, and they said, we don't know what any of those words mean. If I saw that in a form, I would just skip that question. So they had a discussion and came up with what their understanding of DKA is. So when you have high sugars and high ketones, that require admission to hospital. So I suppose that's just an example of a small thing, but something that makes a massive difference in terms of outcome measurement. A question that previously would have been skipped by a lot of the participants now is a very answerable question. We also have a lot of qualitative work going on throughout the pilot RCT to assess the feasibility and acceptability of both the intervention and also going to a full-scale RCT. So the young adult panel created the interview guide. One member piloted it with the qualitative researcher. And then at the midpoint of the trial, she met with them and they gave guidance around what themes she should be delving in further, how she should modify her interview guide based on what she'd found so far. Like Sean just mentioned there, we just had a meeting on Monday where she presented her final kind of draft of the themes. She's finished her qualitative research now, and it was just so exciting to discuss it with them and to see how they were interpreting and explaining those themes. It was brilliant. So I'll just leave you with this, which is just one kind of small thing we've been working on as well for the last 12 months. When we got the funding to do the pilot randomised control trial, we also got funding to do a SWAT, or a study within a trial. So a SWAT is a self-contained research study that has been embedded within a bigger trial with the aim of looking at how the trial process could be improved. So it's always something to do with the trial process, and they usually focus on recruitment or retention to the trial. So we knew from the beginning that this was something that the young adult panel were going to lead on. So we had a discussion with them around what they thought would be a useful question to answer. The Northern Ireland Trials Methodology Research Centre actually have a repository of SWATs that have been done that you can, duplicate and add your results to. So we had a look through that to see, was there anything that they kind of thought was interesting and would be worthwhile exploring. So the question we came up with was, does receiving a branded gift and letter increase the likelihood of someone filling in the final questionnaire? So I had ideas for the branded gift, like maybe a USB stick or a pen, but the young adults weren't having any of that. And what we have now is a pop socket. So I'm not sure if you guys have those. They're it's like a little grip you put on the back of your phone, and then you can kind of hold your phone for taking selfies. So we have branded D1 Now pop sockets. So how our SWAT worked was at the midpoint of the trial, half the young adult participants would have received a pop socket and also a letter from the app. So you can see the letter kind of says things like, this research has been co-created with a diabetes research team, but also the young adult panel. We're really grateful for you for taking part in this trial. You're allowing us to reimagine type 1 diabetes care, and then asking them to fill in the final questionnaire when they receive it. The control group then received the pop socket as well, and just a letter saying thanks, and they received that at the end of the trial, so when everything was finished. So in terms of the future for D1 Now, we're finishing up the pilot trial at the moment. I suppose we're just trying to gather our thoughts, work on our dissemination strategy. We're thinking about maybe hosting a conference where we pull people from all around the world together and figure out where this work is going to go next. It's all going to be led by our young adult panel, and they will play a really big role in this. And then finally, just a little plug for a documentary that we were involved in last year. Actually, no, it was in 2018. So as Sean mentioned, PPI, it stands for Public and Patient Involvement. That's what we call kind of co-development work in Ireland, and I think Europe more broadly. So it was a documentary about PPI, and it featured our young adult panel. So you can catch the trailer there on Vimeo, and I think it's regularly screened at kind of science film festivals, so I'm sure it's due a screening again soon. So I think that's it from me. I'll stop sharing my screen.
That was excellent. Thank you. That resonated on so many levels with the work we do.
Great.
And where we're at, I wasn't looking at others, but I'm hoping Conrad and Nico were shaking their heads like, yeah, this is in line with what we've done within our group. I'll just turn it over to our partners here. Sylvie, Dinneen, Conrad, do you have any questions first?
No, not for me.
Yes, maybe I can have a couple. Just by beginning, I'm not English is not my first language, so if you have any, if I'm not clear, let me know. I was wondering, when you are talking about the support worker, did you think about using a kind of a person with diabetics as a role, play that role?
Yeah, it's a really good question. Eimear, do you want to handle it?
Yeah, sure. So I suppose, do you mean somebody who's living with type 1 or somebody who's experienced of working in the area?
No, somebody is living with type 1.
Yeah, so I suppose it is something that would be obviously of interest, and would be, would be brilliant to get somebody who could bring that lived experience to the role. I suppose we weren't able to specify that in a job spec. I think that would probably go against some kind of employment rights issues, although maybe the opposite of how it normally works. So it wasn't something that we could specify within the job spec. But I agree that somebody who is living with type 1 can bring a great lived experience and insight into a role like that.
So I was wondering if you have a chat about that or not. But I understand that may bring some difficulties to bring somebody specifically with type 1. So, yeah. May I have another one?
Sure.
Yeah, I was wondering also, if I understood well, you said at the beginning that you the people, when you create the hackathon, the people were creating the kind of a pitch. You create teams and then you create a pitch. What did happen after that? They have diversity as their view and they have to bring that together, or is it, how did it work?
Yeah, I mean, I can look harder. I couldn't find the brief that they were given, but they were given a task, and it was something like, you know, you need to come up with a solution that, you know, involving technology that would help with young adult type 1 diabetes care. It was something very broad like that. So it didn't specify, because of course our D1 Now study hadn't been born at that stage. You know, it was very broad. It was just, so some of them came up with ways of trying to get diabetes education, you know, better delivered or coordinated. Like, it wasn't necessarily around clinic attendance. The winner of the hackathon was a team that I had to figure out what it meant, but Snapchat was very popular in Ireland at the time. And this idea came from the young person saying, well, you know, I'm not going to look at a message from my diabetes clinic, but I'm sure I'm definitely going to look at my Snapchat. So they created this idea of messaging through Snapchat, you know, just not incessantly and not in an annoying way, but things that might be relevant and perhaps motivational to a person, you know, related to their diabetes. That's my recollection of the winning pitch. And it's interesting because the Florence SMS messaging app is not a million miles from that idea. You know, it's about nudging. It's just, you know, the idea of Florence is that, you know, you discuss something during a clinic visit, and then ideally you individualize the messaging and you say, remember that, you know, and you just sort of nudge. So it's an interesting, I think, yeah. So it was broad, but it was also, it had to be relevant to the direction of travel.
Yeah, I can jump in there as well, Sean. So that happened in 2016. I wasn't working with D1 Now at the time. I was still doing my PhD, but I participated in the hackathon as a health psychology researcher. And we were, what the real strength of it, I felt, was the way we were broken up into teams. So in my team, there was me as a kind of a health researcher, and one of the young adult panel, so a young person living with type 1. We had a diabetes nurse. I think maybe we had another diabetes healthcare professional as well. And then we had some tech guy. I think he was kind of computer science guy. And what was brilliant was that we were kind of thinking up of all these big ideas, but then everybody was able to put some boundaries on it. So, you know, we would think of an idea and maybe the diabetes nurse would say, well, look, really that wouldn't work in clinic. Or we'd think of some real blue sky idea and the tech guy would go, well, look, you'd actually need about $3 million to realize that. Or we'd think of something and Kira, who's on the young adult panel, would say, I would never use that. So it was having that diversity within the team of the different kind of skill sets and backgrounds meant that I suppose you came up with something that in the end you hopefully met the requirements of everybody.
But I think two elements, I tried to reflect it in the comments I made, but two elements I think of the success. One was, it was a real pressure pot. You know, you knew that you had a limited amount of time. You know, that pre-hackathon meeting in the evening had some sort of boundaries put on it. And then on the day, you know, they worked feverishly, they worked really hard, but they knew that they had to come up with this, you know, this pitch at the end. And the second thing, which I don't know how it happened, it just happened, but it was great fun. You know, it was absolutely, you could just, the energy in the room was phenomenal. And I think that was probably down to the guy who did the MC. He was very good at what he did, you know.
Have you thought about how you're going to deliver a hackathon virtually?
We've been passing around some ideas, and one of our one of my goals for the webinar series is to have someone from the MIT Hackathon group come in and describe how they've pivoted. But we're trying to break it into smaller chunks, 2 small shorter afternoon windows, so that we could do that. But I agree. So the breakout rooms and the relationships are really key. Diabetes Action Canada, our network, typically we met as a group. So all the scientists, all the patient partners would come together for 2 days in Toronto to meet. And those are great energy building moments. And we break out into small rooms and discuss progress, and people get to really interact. And I think that's a strength. So we really wanted that face-to-face. It's so essential. And I do a lot of work with Indigenous communities here, similar to Native American, and relationships are just paramount. So we have a good relationship. Our group has all been virtual since the beginning. I think we all kind of know each other through that, but it would be great to meet face to face. So we're still working on that. One of my questions about the hackathon, specifically, empowering the participant voice. So particularly a young voice. So if you're at a table with doctors and nurses and experts and you're a young adult, you may feel not empowered. Did you have any strategies for highlighting the voice of the patient partners in those small group meetings?
Yeah, it's a good question. And Eimear can comment based on her experience in the hackathon. I kind of floated. I didn't participate in any one of the 4 groups. I was kind of one of the adjudicators, but I did get the sense, certainly in the team that won, and I don't think this was prearranged, but there was a diabetes nurse who was familiar with the young person, and I think that helped. There was somebody in the group that the young person knew from before. All the others were the techies and the researchers and so on. But I'm not sure how you manage that, or if because you could end up trying to manage it and it could end up backfiring. It's a difficult one. But Eimear, how did it work in your group?
Yeah, well, I suppose what I felt really helped with that was the fact that this was kind of a 3-day event. So anyone who was at the hackathon had attended the conference that was on the first day. And I mean, the conference was all about the young adults. So they were really, like, everybody who spoke at the conference spoke about how important the young adult involvement was. 2 of the young adults actually spoke at the conference, and I think we were all so blown away by them. Like, I thought they were just rock stars. And I really felt that kind of respect in the group that I was in. So definitely in the team I was in, the young adult who was living with type 1, she was definitely the youngest person there by far. But I mean, we were all, anytime she spoke, we were all kind of stepping back and listening to her more than we've listened to anyone else, I think. And I think that was just because the importance of the young adult voice had been emphasized so much in the days leading up to it. Yeah, that it kind of led to that.
That's an interesting observation. I think Eimear is spot on. I mean, the standout moment for me we had the cost, the core outcome set first, which was sort of work, jobbing work. Then we had the conference, correct me if I'm wrong, and then the hackathon. Yeah. Is that right, Eimear?
I think so, yeah.
Yeah, and the standout moment was one of our young adult panel gave a talk at the conference. Now, this was a pretty daunting, it was in our quadrangle in our university in what's called the Aula Maxima. So it was a fairly official, looking place. And she had her talk prepared, but she went off script at the end and spoke very, very movingly about how she would not be a beneficiary of this work. And it was this idea that she was doing it for the next, she was approaching 25, or, she was in that age group where she would be moving out of the young adult clinic or moving out of the young adult kind of setting. And you could hear a pin drop, and I think that really set the tone, for the rest of the event, this idea that, this is important. It's not just important for me, as an individual, it's just important. So yeah, I don't know. I feel very lucky to have been part of it. It was a coming together. It was like the stars or the planets kind of aligning, and a lot of, we got a lot done in that 2.5 days. as Eimear alluded to, we're hoping to do it all again. So we'll probably be back, knocking on your doors, because we want to take this work forward, and we want to try and, learn from what we've done, but also, there's some really good work, not a lot of good work going on in this space. When we looked at the literature, there's not a lot of people working in the 18 to 25 year age group. I think because it's just so difficult to do good work in that whole area. But we've connected in with an endocrinologist, adult endocrinologist in London, Ontario, who's published in diabetes care on a really good transition from pediatrics into adult. Tamara Spake, S-P-A-I-C. You may have come across her work, but she used, interestingly, they have a similar approach. They kind of came up with a transition worker, they called the person, to help the young person transition well. But we're hoping to pull together a group maybe in the second half of this year, and again try to get those creative juices flowing, and just brainstorm and learn from what we've gleaned so far, but also sharing it with yourselves and hearing your story in a bit more detail maybe.
I just have a question here from Conrad. So with the concept of nudging and changing behavior, how do you think this will factor into pushing to more virtual care visits now and having a virtual platform to manage diabetes? Because that's unfortunately the realm that we're in now. Yeah,
it's a good question. And, I don't know. We're still analyzing and still trying to distill out, the messages from the pilot. I think that nudge, or that, I think there does need to be some contact, some communication between the young person and the clinic, between visits. But we haven't figured that out. I mean, there's a what would you say? It's in my head, it's like a Venn diagram. The support worker, the messaging app, and the agenda setting tool. There's overlap, and I think the support worker is the key. I think to creating an environment that is seen to be supportive, as opposed to the wagging the finger, which is often how our clinic visits are perceived, in my opinion. But I'm not sure. Eimear, do you have any thoughts on what Conrad asked?
Yeah, sure. So I think we ran this pilot trial from October 2019 to January 2021, which obviously, unfortunately, took in the COVID-19 pandemic. So that did mean that I suppose we were quite lucky in a way that we were running a pilot trial and not a full-scale RCT, where we would have been very stuck to the protocol. Around, I think in March of 2020, diabetes care here in Ireland went more or less virtual. So all outpatient clinic appointments that had been happening in person up to that date went virtual. So that also meant we had to deliver the intervention virtually as well. And we had to pivot a little bit and kind of figure out how we would deliver it online. So as Sean said, I don't think we figured out yet how the virtual platform interacts with the idea of nudging through messages. But we have, I suppose, one benefit of this is that we've got heaps of qualitative data about it now that we didn't anticipate having this time last year. And maybe that is one good thing that the pandemic did bring about, was that now we will be able to think about delivering this in a virtual context, which might be the way forward anyway.
My own feeling, Conrad, on the three components of the intervention, I mentioned that I think the support worker is the key, to bringing it all together. But I think acknowledging diabetes distress in this cohort is something that we have not done well, as a healthcare professional kind of community. I think we know there are high levels of distress in this cohort. A lot of them just hate having type 1, that's the bottom line. And I think, acknowledging that, you can't wave a magic wand and fix it, but if you ask about it, which is what the DDS2 the questionnaire does that, and then just have a conversation about it. You know, we have very little psychology support in our clinics in Ireland, but I think, you know, any diabetes healthcare professional can administer the DDS2. The agenda setting tool facilitates that. But I think asking about and talking about distress is a big part of what I think will be the solution, if you want to call it that, or, you know, the way forward. I'd be interested in Dinneen or Sylvie's thoughts on that. I don't know if it's the case in Canada that, you know, young people struggle with this condition.
Don't know. I'm not young anymore, but I guess that, at my point of view, yes, it's a big deal, because I think that this life with the T1 is like walking on a wire, and it's sometimes you are unable to, and you don't know why the wire move, and and you don't know, and sometimes you're tired. That's all.
Yeah.
But if you're young, it's probably much more complicated than that.
Yeah.
Yeah, and I'll jump in a little bit here and just say it's this young people with type 1 or type 2, I think, struggle with maybe a singular focus on A1C and thrive in shared decision making. They just thrive in that ability to say, look, I want to talk about what I want to talk about.
Yeah.
You know?
Yeah. And why has it taken us decades to figure that out, you know?
Yeah. I just sent you some links. We have a transition program here in Winnipeg. And also
that's great.
some things with some other youth we've worked with. We started by making videos, and one of our other projects in Diabetes Action Canada is to get the patient voice through video to talk about some of these things. And that's exactly what people talk about: the stress, the weight of diabetes always being there. And so it's really something that, regardless of age or regardless of type of diabetes, I think people want to talk about.
Yeah, the ADA over the pandemic did put out some useful webinars, you know, people talking about different aspects of delivering diabetes care. I patched in on one on diabetes self-management, and it was really useful. You know, no drugs, no devices, no seat, nothing like that mentioned. It was just, how do you interact? You know, how do you bring, and they did it across the age spectrum. So pediatrics, they did young adult, which I was really impressed with, and then, or they called it emerging adulthood, and then they had adult and senior. You know, and there are skills, there are differences in those age groups, and you know. The question I really liked was in the young adult setting, you know, what do you find the most difficult thing about living with type 1? You know, and just that question, it's already what's the word? It's like an acknowledgement that it is difficult, you know. So you're sort of saying, well, I know that from talking to people, it's tough. What do you find tough about it? And I think that sort of language matters, you know. It really makes a difference. So
agreed.
Yeah.
And I think on that note, it's 5 o'clock your time, and it's time for probably us to have a snack as well here. So that was wonderful. I'm so glad we got to hear from you, and you will be part of our team and our family moving forward. I can guarantee that those experiences are really going to help. So I look forward to connecting with you in the future. And we'll loop you into our future webinars as they come up, and hopefully this is the beginning of a relationship moving forward.
Great.
Yeah, thank you so much for having us.
On a side note, I was part of an Ireland Canada University Foundation ICUF grant.
Okay. Oh wow, where did you go?
ESRI in Dublin.
Okay.
And so maybe this is an opportunity for us to work with that foundation, also to have some type of collaboration and funding for you know,
that would be
working in each other's labs. So
yeah, Eimear and I talked to our support worker Michelle yesterday, and we're hoping to explore this diabetes distress thing in a bit more detail. Through Michelle is doing a master's in diabetes research in our university, so we will have elements or strands apart from landing the big fish, which is, you know, a definitive trial, but we will hopefully have aspects of our work that we can tic-tac with you on and see. where it takes us. Yeah.
Yeah.
Great. Well, thank you to everyone who came on. Merci beaucoup à tous. On va avoir une réunion bientôt. And so thanks again to Sean and Eimear for this wonderful talk. It was a really great way to kick off our webinar series. And we look forward to working with you in the future.
Take care.
Thank you.
Thank you.
Take care.
you.
Thank you very much.
Take care. Bye-bye.
Bye-bye.